Radial nerve may be injured at the elbow, in the upper arm or in the axilla. Clinical features. Low lesions are usually due to fractures or dislocations at the elbow, or to a local wound. Iatrogenic lesions of the posterior interosseous nerve where it winds through the supinator muscle are sometimes seen after operations on the proximal end of the radius. The patient complains of clumsiness and, on testing, cannot extend the metacarpophalangeal joints of the hand. In the thumb there is also weakness of extension and retroposition. Wrist extension is preserved because the branch to the extensor carpi radialis longus arises proximal to the elbow. The wrist is seen to extend into radial deviation without the balance of the extensor carpi radialis brevis. High lesions occur with fractures of the humerus or after prolonged tourniquet pressure. There is an obvious wrist drop, due to weakness of the radial extensors of the wrist, as well as inability to extend the metacarpophalangeal joints or elevate the thumb. Sensory loss is limited to a small patch on the dorsum around the anatomical snuff box. Very high lesions may be caused by trauma or operations around the shoulder. More often, though, they or due to chronic compression in the axilla. This is seen in drink and drug addicts who fall into a stupor with the arm dangling over the back of a chair, Saturday night palsy, or in thin elderly patients using crutches, crutch palsy. In addition to weakness of the wrist and hand, the triceps is paralyzed and the triceps reflex is absent.